I think 1.5 hours serious case from it's always a very tough case. So let us relax with the nephrotic syndrome. There's a long bond between me and this nephrotic syndrome because I was looking after the nephrotic OP for nearly 10 years from 2007 to 2017. And so, 10 வருஷமா I was registered in RENAL Medical College. No, CPS கொடுத்தாலே பசங்க டென்ஷன் ஆயிடுவாங்க. லாங் கேஸ் முடிச்சுட்டு அடுத்து ஷார்ட் கேஸ்க்கு யூஸ்வலாக லாங் கேஸ் நம்ம லாட் போட்டு அலாட் பண்ணி கொடுத்துருவோம். லாங் கேஸ் முடிச்சுட்டு ஒருத்தரா ஷார்ட் கேஸ் அலாட் பண்ணுறப்போ நேராக பிஜியை முடிச்சுட்டு பார்த்தீங்கன்னா 10 பேர் நெஃப்ராய்டிஸ் சிண்ட்ரோம் முன்னாடி தான் போய் உட்காந்துருப்பாங்க. இப்போ டவுன் சிண்ட்ரோம் இருக்குன்னா தோற்று கொடுக்கணும். சார் மேடம் சொன்ன மாதிரி டெமான்ஸ்ட்ரேட் ரிஃப்ளெக்ஸஸ் அதெல்லாம் அது மாதிரி நெஃப்ராய்டிஸ் சிண்ட்ரோம் அது கஷ்டமே இல்லை. நான் மோஸ்ட் ஆஃப் தான் ட்ரீட்மெண்ட் ஸோ ஃபைண்டிங்ஸ் எதுவும் இருக்காது. ஜஸ்ட் கேஸ் டிஸ்கஷன் மட்டும்தான் இருக்கும். மேக்ஸிமம் சில பேஷண்ட்ஸ்க்கு அசைட்டிஸ் இருக்கும் அல்லது குசிங் சிண்ட்ரோம் ஃபியூச்சர்ஸை டெமான்ஸ்ட்ரேட் பண்ணாடி இருக்கும். ஸோ அதனால் எல்லா பசங்களும் 12 பேர் போய் இருக்கணும் நெஃப்ராய்டிக் விளையாடு தான் இழுத்து கொண்டாந்து தான் மற்ற கேஸில் விளையாடி இருக்கும். ஸோ ஆல்வேஸ் ஐ ஹாவ் a special bond with nephrotic syndrome and even my students who are finished and who are now consultants, எப்பவுமே நான் போஸ்ட் போடுறப்போ சொல்லுவேன் nephrotic syndrome தான் எல்லாருக்கும் ஸ்டூடெண்ட்ஸ் ஃபேவரட் அப்படின்னு சொல்லுவாங்க. நானும் nephrotic syndrome கண்டிப்பாக தான் சார் வாங்கலான்னு சொல்லுவாங்க. ஸோ I love nephrotic syndrome patients. Yes.
Good morning, professors, and good morning, my friends. So today we will be presenting nephrology case. I myself am Abhijit. This is Abhishek and Rajanan. So we'll start the case.
So let's get practice session. Don't be tense. Feel free to ask doubts anywhere. Okay. So we'll discuss after now. Okay.
So patient details. The name of the child is Master Vijay. He is 6 years old, male child. He is from Kulisagam. The informant is his mother and she is reliable. Going to chief complaints. Patient puffiness for 7 days. History of presenting illness. He was apparently normal until 1 day back when his mother noticed puffiness of face, initially around the eyes, which is more in the morning and it decreases as the day progresses. She also noticed decreased urine. The urine was frothy and started 5 days back. This was the first episode.
So, what do you understand from this? So, the first paragraph itself, you can identify the system. How can you?
Renal system.
Why do you say renal system?
Edema. Puffiness.
Yes. So, just mostly concentrate on the exam asked questions. I have been examined for nearly 10 years, so I know what all the last one. Okay. So, regarding edema, the differential diagnosis will be renal system, cardiovascular system, there is a hepatic system, or in pediatrics can also take into consideration SAM or quashiator. Okay. So each edema presents differently. Okay. So why do you say it's a renal system? Yes, okay. So in renal edema, only the edema will be periorbital puffiness, more prominent during waking, and it will gradually disappear as the day progresses. Okay. Can anyone say how that will be the cardiovascular edema? Because dependent edema. Okay. And those mobile patients will be renal edema, and those babies who are not mobile, that will be the edema. Yes, pre-sacral edema. Okay. And where will be the hepatic edema? It will present first ascites. Okay. And differentiate also quashiator. There will be skin changes, sometimes hair changes. Okay. So this will be the differential diagnosis, and in the first paragraph itself, you will say that this is a renal system. Okay.
No history of blood in urine, no history of fever, no history of sore throat or skin lesions, no history of breathlessness on exertion, chest pain, no history of recurrent infections, weight loss or bony pain, no history of crying during intubation or increased frequency, no history of insect bite, no history of pain abdomen, no history of headache, no history of rashes or joint pain, no history of recent upper respiratory tract infections. Treatment history, the child was not on any regular medications.
This is the first episode.
Past history, No history of similar episodes of facial puffiness, decreased urine output, blood in urine, fever, sore throat, skin lesions in the past. No history of contact with TB patient. No history of jaundice. Family history. No history of renal diseases in the family members. No history of hypertension, diabetes, tuberculosis in the family members. Antenatal history. Mother says at conception, 23 years. Her antenatal checkups are regular and it is uneventful. The child is firstborn out of non-consanguineous marriage. Natal history. Full term, normal vaginal delivery to institutional with a birth weight of 2.5 kilograms. Baby cried immediately after birth and was breastfed within half an hour of delivery. Neonatal history. No history of feeding problems in the neonatal period. Dietary history. Child was exclusively breastfed for 6 months. Complementary feeding started at 6 months. The calorie intake of the child is 1206 kilocalories and the required intake is 1480 kilocalories, a deficiency of 274 kilocalories. In protein intake is 34 grams and there is no deficiency. Required is just 23.3. This data is from the ICMR National Institute of Nutrition 2020 report. Immunization history. Child is fully immunized according to National Immunization Schedule. Last vaccine was given at 5 years of age, DPT booster and OPV. Child did not receive pneumococcal vaccine. Developmental history. All gross motor, fine motor, personal, social, language milestones were attained at appropriate age. His scholastic performance is good. Socio-economic history. Belongs to class 3, lower middle class of modified Kuppaswamy scale.
Moving on to general examination. The child is conscious, alert and active with no respiratory distress. Vitals. Pulse rate is 72 beats per minute. Rhythm is regular. Volume is normal. Character normal. All peripheral pulses are felt equally on both sides. Blood pressure is 104/66 mm mercury in right upper arm in sitting position. Systolic blood pressure is less than 98 percentile and diastolic blood pressure is less than 98 percentile. Both are normal. Respiratory rate is 18 breaths per minute, thoraco-abdominal. Temperature is afebrile. Then head to toe examination.
Always never forget to record BP. Okay, record the case. There will be a cardiovascular case. This is recording. Okay, panama eligible get patient. BP getting okay. So always try to record the BP. Get an appropriate size cup from the register. Okay.
Head to toe examination. Facial puffiness is present. Periorbital edema involving eyelids present. No ear abnormalities. No sore throat lesion. Skin lesions or rashes are seen. No joint swellings. Loculombar or other cushingoid fascias. Bilateral pitting pedal edema is seen. No pallor, icterus, cyanosis, clubbing or generalized lymphedema will be present. Anthropometry. The expected weight of the child is 19 kilograms and the observed weight is 20 kilograms. Interpretation is between 0 and 1 standard deviation. Inference is normal. Height is expected is 115 centimeter and the observed height is 116 centimeter. Interpretation is between 0 and 1 standard deviation and inference is normal. Weight for height of the child, expected height for height of the child is 20 kilograms. Observed is also 20 kilograms. Inference is normal. BMI of the child is 14.9 kilogram per meter square. Expected is also the same. So inference is normal.
Yes, it's not a case of protein edema deficiency. So the plot pretty collected. Take copies, take plot find quantities. So try to plot and learn. Example plot marks.
Systemic examination. Upper GI examination is normal. Inspection of abdomen. Abdomen is not distended. Skin over abdomen is normal. Umbilicus is centrally placed and inverted. All quadrants move equally with respiration. Striae is absent. No visible gastric pulsations. No engorged veins or sinuses. No scars are seen. And flanks is not full. Palpation. On palpation, the abdomen was soft and not tender. There is no local rise in temperature, no epitomegaly or splenomegaly, no other mass was felt, no tenderness in the renal angles. Percussion, the liver span was percus 2 to 7 cm, puddle sign was positive, shifting tunnels was absent.
How will you examine first shifting tunnels? From where will you practice?
From flanks to central, sir.
From
Sir, first the patient is made to lie in the supine position, sir. And
in the medicine department.
yes,
as you can what's done,
yes, sir.
you can demonstrate it from where. Hello, you can
So where are you starting? What you did was right. From center to center. But you said from the flank.
other shifting, yeah. Will shift turn the patient, wait for something, and then again demonstrate. Okay. So when the fluid is more than 1 liter, you can come fluid. Yeah, the basic have to do 16 liters. And for minimal fluid, what will you do? And we question the availability of sparring. And minimal fluid, and I'm going to get puddle sign. And how will you demonstrate puddle sign? Okay, yes.
Auscultation, the normal bowel sounds are heard. External genitalia examination, it is normal and there is no scrotal edema. Other system examination, cardiovascular system examination, S1 and S2 are heard with normal intensity, no murmurs or added sounds. Respiratory system, air entry is equal on both sides, no dullness and percussion, normal vesicular breath sounds are heard. Nervous system, there is no focal neurological deficit. Summary, a 6-year-old male child came with complaints of first episode of facial puffiness for 7 days and frothy urine for 12 days with no history of hematuria, fever or sore throat. There is
Why do you stress on hematuria?
nephritic syndrome.
The close differential diagnosis will be post-infective glomerulonephritis. So where hematuria will be more prominent. Okay, so one of the differential diagnosis. Yes.
There is no history of renal disorders in the family members. On general examination, facial edema and bilateral pedipedal edema is present. There was no hypertension. On local examination, no abdominal distension was seen. Puddle sign is positive. No organomegaly, no renal angle tenderness. My probable diagnosis is the first episode of nephrotic syndrome with minimal ascites and no other complications.
Yes. Why do you say it's nephrotic syndrome? See how quick are these are. See this so I know you are why they are referring nephrotic syndrome. Yes. Why do you say it's nephrotic syndrome? It's a clear-cut diagnosis. Most common renal problem in children is nephrotic syndrome, and rarely they get glomerulonephritis. Where it will be a short duration, hematuria, hypertension. So when they differentiate between the customer. Okay. So why do you say it's nephrotic syndrome?
So first from the age, sir, age is more common in less than.
What's the typical age group of nephrotic syndrome?
2 to 6.
Yes, that's a child is
6 years old.
Yes.
Then it's more common in male side.
Okay.
So then moving on to symptoms, facial puffiness. This is more prominent in nephrotic syndrome, sir. There is no hematuria. Hematuria is seen in nephritic syndrome. Hypertension is also seen in nephritic syndrome. Very arbitrary.
It's probably yes. And that's a minimal ascites. So this the most common problem in renal problem in pediatric will be nephrotic syndrome. Okay. How do you manage the patient?
Diagnosis, it is the first case of first episode of nephrotic syndrome with no other complications.
Wound investigation, urine analysis, plasma protein, RBC 2 to 4, RBC per hyperfit, WBC 3 to 5,
It's an
WBC
acid bacteria.
hyperfilled, and hemoglobin 12 gram per deciliter, PCV 37%, serum urea 17 milligram per deciliter, serum creatinine 0.6 milligram per deciliter, total protein 4.5 gram per deciliter, albumin 2 gram per deciliter, globulin 2.5 gram per deciliter.
What's the difference?
Hypoalbumin.
Yes, normal serum albumin will be around 3.55, and here the albumin is 2. So what's the normal albumin globulin ratio, and what happens in the practice?
1.1.
Yes, normal albumin globulin ratio. Normal albumin is simple, 2:1. Okay, and there's reversal of albumin globulin ratio in the water. Normal albumin globulin ratio is 2:1, and there's reversal of albumin globulin ratio in the water. Okay.
Cholesterol 270 mg per deciliter.
Anything beyond 200 is hypercholesterolemia. Yes.
Sport urine protein creatinine ratio 3.4.
So what's the difference?
Nephrotic renal.
Difference. Anything more than 2 is nephrotic renal. Yes.
Urine analysis, biochemical evaluation, blood urea, serum albumin, serum
You
creatinine,
not
serum.
correct for the protein. Big one. 30% protein not done. It's a 6-year-old child.
USC, urine culture, other tests for hepatitis B and C, HIV, anthrax, and chest X-ray. If hematuria is present, then ANA, serum C3 and ASO titer should be investigated. Treatment, first is diet management. A balanced diet with adequate protein, 1.5 to 2 gram per kilo, and calories. Fat less than 30% calories. Avoid saturated fats. Salt restriction 1 to 2 gram per day.
What about fluid? Fluid also?
General management is nice slides.
Medical management, prednisolone oral 2 mg per kilo daily for 6 weeks, maximum up to 60 mg. Then prednisolone oral 1.5 mg per kilo on alternate days of 6 weeks. After 1 week, steroid and elemental calcium 20 mg per kilo body weight, and vitamin D 600 international unit daily. Give
All these nephrotic patients, they are prone for hypercalcemia and vitamin D deficiency. So we substitute calcium and vitamin D.
Give pneumococcal vaccine, treat infection before administration of steroids, maintain renal salt, daily weight, BP and abdomen.
What are the 2 infections you rule like to rule out before starting steroids? Yes, 2 infections. One is urinary tract infection. Silent urinary tract infection is more common. So always do a urine culture and always rule out tuberculosis also. Okay. Occult say that quarter may become a progressive pulmonary tuberculosis. So always rule out tuberculosis also. Okay. UTA and tuberculosis you have to rule out before starting on steroids.
Abdomen growth, urine albumin, dose of steroids should be maintained in the renal cell. Thank you, sir.
Okay, good. This is simple. Short case, mostly we have just a short case. And we have definition with the techniques. We'll just discuss about what is it. So one disease where you have to understand both physiology, pathology, okay, for diagnosing as well as for treatment. Okay, say what. So these are the properties of nephrotic syndrome. Okay, first one is basic problem is massive proteinuria. What's the type of protein is lost in urine? It's the albumin. Why albumin? Why is albumin lost in urine? Yes, it's a low molecular weight protein. Okay. So due to massive loss of albumin in the urine, you get So another feature is hypercholesterolemia. As I said, cholesterol level more than 200. And with or without edema. So why do you get massive proteinuria? What's the problem? What's the basic problem? Now, adults 120 milligram per day is toxic. Okay? So there are some defense mechanisms in the glomerular basement membrane to prevent the filtration of albumin. So we have some basement membrane food processes and there are negatively charged particles in the food processes or the basement membrane. So albumin is also negatively charged. So what happens? This negatively charged repels the negatively charged albumin, so that albumin cannot be filtered through the basement membrane. So what happens in nephrotic syndrome? So it's negatively charged. Okay. In mostly the common type of nephrotic syndrome in the pediatric group is minimal chain disease. Okay. So in the minimal chain disease, those negatively charged particles are lost from the glomerular basement membrane. So albumin cannot be repelled and albumin is massively filtered. Okay. So this happens without any mechanical damage to the glomerular basement membrane. So another normal check only we see through the electron microscope, we will see loss of food processes. Minimal chain disease what's seen here is loss of podocytes or loss of food processes in the glomerular basement membrane. Okay. So why the negatively charged particles cardiopathia? So in the cardiopathia, the theory is that there are some abnormal lymphocytes which secrete abnormal lymphokines that cause the loss of negatively charged particles from the glomerular basement membrane. So another steroids go through and the lymphocytes are suppressed. Again, the negatively charged particles reappear in the glomerular basement membrane. Okay. So that's a massive excretion of albumin in the urine. So this leads to hypoalbuminemia. Okay, albumin level drops below 2.5. Okay. So how edema appears? The question came up. How does edema appear? There are two factors which decide the fluid in the interstitial space. One is the hydrostatic pressure in the blood vessel that pushes the fluid out. Okay. So after circulation from the venous end, the fluid is pulled back by the aquatic pressure. Okay, these two factors decide the fluid balance. Okay, so what happens in the that's albuminemia, hypoalbuminemia. So albumin decides the aquatic pressure. So that's a massive fall of aquatic pressure. So another volume of fluid it cannot be pulled inside. So fluid is pushed out by the hydrostatic pressure, it cannot be pulled back into the circulation. So the fluid accumulates in the interstitial space, so only you are getting the edema. Okay. So what happens is, even though the child is edematous, what will be the status of the intravascular volume? Actually, nephrotic syndrome patients, this is the basis for treatment. In the basic edema, treatment will go wrong. Okay. Maybe edematous the intravascular circulating volume will be low, that is hemo concentration. Okay. So we have to maintain the hydration properly, otherwise the child will go for intravascular clotting, cerebrovascular clotting, renal fibrosis, or deepening thrombosis of the legs. Okay. So that's one main reason that the aquatic pressure, hydrostatic pressure is not the only reason. Another one reason is, since the circulating volume is low, the renal perfusion will be low. So what happens? What is activated? So juxtaglomerular apparatus is activated. So you get the activation of the renin-angiotensin-aldosterone axis. So what's the final function of the aldosterone? So it leads to sodium and water retention. Hope everyone understand that? So now the sodium and water retention continues high-tech, the child becomes massively edematous. Okay, these two theories: aquatic pressure reduction and then activation of the renin-angiotensin-aldosterone axis. These two lead to a massive edema if untreated. So as I said, we classify the primary or secondary. Mostly we get a primary. Primary, most common one will be the minimal change nephrotic syndrome. That's typical frothy urine, no hematuria, no hypertension, no elevation of renal parameters. Okay, so it responds to steroid. Yeah. So rarely you do get focal segmental glomulostenosis, membranous proliferative glomerulonephritis, membranous glomerulonephritis, or some IgA nephropathy. Okay, what are the other causes of data? You have to say all these things. But you should remember minimal change nephrotic syndrome. Okay. And it may be secondary to SLE or infections like hepatitis B, C, HIV, okay, malaria, drugs like penicillin, and rarely bee sting allergy. Still no history of bee sting allergy. So rarely it may cause secondary causes for nephrotic syndrome. So this is the typical periorbital puffiness. Okay. Inshallah, daytime prominent morning is the so as the day progresses, the edema will regress. So if untreated, this leads on to anasarca. See massive ascites, this scrotal edema, renal edema, and untreated. Okay. So this is the typical renal edema and massive ascites. The more ascites are fluid. So typical edema of the scrotum, ascites, pleural effusion. Okay. Then there may be fever, peritonitis, cellulitis, scrotal cellulitis, we have seen in a lot of cases, okay? And even shock. So they will ask about difference between nephrotic syndrome and acute glomerulonephritis. So it's a slow in onset. Nephrotic syndrome is slow, acute glomerulonephritis is acute in onset. Okay? That's a massive edema. Anasarca, this edema is minimal. But hematuria and oliguria will be prominent. So there will be hypovolemic shock, but there will be hypertension. Mostly acute glomerulonephritis hypertension. Acute glomerulonephritis is mostly caused by renal alpha. What's the reason for acute glomerulonephritis? Yes, you will have a streptococcal skin infection, streptococcal hepatico, followed by hematuria and oliguria. This is pathology. There's an antigen antibody formation, complex formation that gets deposited in the glomerular basement membrane, and that activates the complement, and complement damages the basement membrane, causing hematuria. At the end of urine is typical polar color urine. Cause of polar color urine? Yes, I can say it like this. There's acid hematine formation on the wall. Acid hematine. So because of hypertension, the patient will end up in hypertension encephalopathy. Canada, seizures over patients, we ask them to measure the blood pressure. Then a time, seizures over the presentation, next day after yeah. So then another important feature is they lead to hypertensive cardiac failure. Okay. In nephrotic syndrome, there will be urea creatinine will be normal. In age, urea creatinine will be elevated. In nephrotic syndrome, cholesterol will be elevated. In age, cholesterol will be normal. That differentiate. Difference between age and nephrotic syndrome will be asked for you next time. So as I said, the investigations are okay. We have basic investigations, and the diagnosis will be clinched with your urine protein examination. Now 3+ or 4+ massive proteinuria. Okay. And to measure the amount of urine the protein is taken in the urine, we need a 24 hours urine protein estimation. 6-year-old child is easy to collect. Okay. 1-year-old child is very difficult to collect the urine, but 6-year-old child go for 24 hours urine protein estimation. For those children, even we do a spot urine protein creatinine ratio. What's the normal ratio? Less than 0.3. And more than 2 is nephrotic. And the 0.3 to 2 is said as nephritic regular protein. So more than 2 normal less than 0.3. Nephrotic is more than 2. Ratio is more than 2. always do a urine culture and sensitivity before we are going to start on steroids. Okay. Then again, X-ray chest and hand to rule out tuberculosis. And finally, do an ultrasound abdomen. Usually, ascites you can diagnose. Otherwise, renal kidney about the such changes in the participant of the can look for ascites. So biochemistry, urea, creatinine, electrolytes, cholesterol, and then LFT. LFT is albumin-globulin ratio is reversed. They'll ask for how will you measure, how look for urine protein, another test for non-common. Now what you do key coagulation for mostly for patient side. Patients test they can test themselves in the house. Usually they are more prone for relapse. Or viral URA start off, the child will start getting edema. So the patient can check at home. Heat coagulation precipitate farmers they can come for consultation. Okay. No, the lab dipstick method. And what we do in hospitals is sulfuric acid method. So dipstick is a semi-quantitative method. Okay. The differentiation between age and angular business one. Okay. So this is the diagnostic trial. Proteinuria is massive proteinuria, hypoalbuminemia with hypercholesterolemia. The diagnostic trial of the participant. So treatment, general supportive, edema management, management complications, vaccination, specific treatment will be cardiovascular. So supportive therapy is always a salt restricted diet, no added salt. Okay. Then fluid restriction. How much amount of fluid would you like to give? They lost. Okay. It's just previous day's urine output plus insensible means unrecognized fluid loss. Okay. Previous day urine output okay. Now adults are 500 ml, children will take it as 300 ml. Okay. So previous day urine output 700 ml now. Insensible water loss 300 ml and 1000 ml then leak 1000 ml. That's milk available 400 ml milk machine 600 ml water. Okay, and 600 ml mother telling 600 ml keep on giving. So measure it. Some bottle 600 ml so 600 ml water mother okay. So fluid restriction is also important for management of edema. Salt restriction and fluid restriction. Okay. So protein as I said 2 grams of protein. Fat should not consume more than 30% of the calories. Salt restriction, fluid restriction. Then edema proper treatment is corticosteroids. And don't treat aggressively with diabetes. Why should we treat? This is clinically a lot of cases. As I said, the intramuscular volume is only hypovolemia. What happens if we take a lot of diabetes? It lead to further concentration and lead to thrombosis. See, in our case, as called for consultation, admit edema 2 days TDS cruise by and child complained of leg pain. Okay, the child was not able to move the legs. So what's the problem the child has developed? Yes, bed restriction board, fluid restriction board, lot of massive deep venous thrombosis extending up to the inferior renal wall. What will happen if a small portion dislodges? Yes, pulmonary embolism and the child will cruise by board the child will be lying dead. So it will happen. So always you have to understand the physiology and understand the edema. You should be judicious to the treatment. So every treatment கேட்குறப்போ judicious use of diuretics அந்த வார்த்தையை சொல்லுங்க. So how can you then treat? எப்படி ட்ரீட் பண்ணலாம்? Steroids okay, it will take some time. Okay. So அந்த எடிமாவை எப்படி கண்டுபிடிங்க? இப்போல்லாம் பரவாயில்ல ஏர்லியாக வந்துருந்தாங்க. நாங்கள் பிஜி பண்ணுறப்ப 2004-05 பேஷண்ட் கம்மிங் ஃப்ரம் ஆந்திரா. பெருசாக மேசிவ் எடிமா கடையாலுமே தெரியாது. ஒரு 1 week கழிச்சு தான் கடையை திறந்து பார்ப்பாங்க. ஓகே. ஸோ நம்ம ப்ராப்ளம் வந்து fluid is lying in the interstitial space. You have to bring back the fluid into the circulation. So what can we do? We have to raise the osmotic pressure. How can we raise the osmotic pressure? Yes, give albumin infusion. It's available, commercially available. 20% human albumin is available commercially. So you can give albumin infusion. So osmotic pressure will rise and then the fluid will now return back into the circulation. Then you can use your diuretics to expel the fluid. Okay. So the pathology and physiology understand பண்ணிட்டு treat. Okay. Bring back the fluid and then treat it with diuretics. Okay. So then, as I said earlier, pneumococcal and H influenza vaccines. So this is the treatment. Treatment treatment for nephrotic syndrome is prednisolone. So first 6 weeks we give 2 mg per kilogram per day daily for 6 weeks. Then it is followed by 1.5 mg per kilogram per day on alternate days for 6 weeks. Then taper and stop. Okay. Most of the minimal change nephrotic syndrome, they are very sensitive to steroids. The child will go in for remission. Okay. So if the child doesn't respond to steroid, then you have to think about other problems. Focal segment, alarm, global, membranous, membrane, polyplegia, you have to suspect. Okay. So what then this nephrotic syndrome is more prone for relapse. Or almost then again the child will be brought back with again relapse and edema. So another relapse we give prednisolone 2 mg per kilogram per day until the child goes in for remission. Okay. Now after that continue 1.5 mg per kilogram for 4 to 6 weeks. So complications and what are the complications of nephrotic syndrome? Massive edema, dyspnea, tachypnea too. Okay. In the child, pediatric infection either known for malnutrition. Then infection. Okay. Then I ask about what is the specific infection related to nephrotic syndrome. Abdominal infection, child born with abdominal pain and fever. So what is the child cause? What is the complication? Yes, called spontaneous alveolar peritonitis. Okay, caused by streptococcus pneumoniae. That is suspect. Sadhana or nephrotic patient abdominal pain, fever or suspect spontaneous bacterial peritonitis. Then cellulitis, pneumonia, UTI. Okay, why are the nephrotic syndrome patients more prone for infection? Yes, one of the first is edema fluid itself is a good culture media. Okay, then there is loss of globulins also, immunoglobulins also in the urine. Okay, loss of complementary factors in the urine. So the defense mechanisms are not both. Then we are giving steroids, it's an immunosuppression. Okay, so these children they are more prone for any pneumonia, diarrhea, UTI, cellulitis, total cellulitis. Yes, in blood, scratch bunny, total cellulitis, whatever. Okay. Then thromboembolism, as I said, thromboembolism because of hemoconcentration, hypertension and shock. Then the child may have hypothyroidism, iron deficiency, anemia, vitamin D deficiency because vitamin D binding proteins are lost in the urine. Okay. So they are prone for vitamin D, we have to substitute vitamin D and calcium. Growth failure and related to steroid toxicity. You get Cushing syndrome. Cushing syndrome. What are the side effects of tyrosine calcium? Cushing syndrome, gastritis, cataract, okay, immunosuppression, they are more prone for infection. Okay. This is spontaneous bacterial peritonitis, as I said. Okay. So suspect one, you have to track the peritoneal fluid and look for cells, more than 250 cells is significant. So thrombosis, right limb is enlarged, deep thrombosis of the leg. The typical patient on long-term steroids, Cushing syndrome. Patient வந்து அதை ரெகனைஸ் பண்ண மாட்டாங்க சார் மறுபடியும் உடம்பு நீங்கிட்டு they come to it's not edema, it's a Cushing syndrome. Okay. So the terminologies வந்து கேட்பாங்க what do you mean by relapse, what do you mean by remission? So remission na you are started on steroids, okay, and the urine album is nil or trace for 3 consecutive days. You can say that the child has gone into remission. Okay. அதே மாதிரி relapse treatment எதுக்கு சடனா ஒரு edema வருது, then look for urine albumin. If it is more than 2 plus for 3 consecutive days, you can say it as relapse. 3 or more relapses in the year, we call it as frequent relapse. So steroid resistant கேட்பாங்க. You are giving full dose of steroids 2 mg per kilogram per day கொடுத்துட்டே இருக்க. Even after 4 weeks the child doesn't go into remission, and you can say it as steroid resistant hepatic syndrome. Then steroid dependent. Steroid dependent na so child remission will go. When you try to reduce the dose or stop the steroids, the child will relapse. So the child is dependent on steroids. You can get a lot of cases of steroid dependent hepatic syndrome. Okay. In a problem of the long run, child will start developing symptoms of steroid toxicity and Cushing syndrome. Then you have to look for alternatives. So, எல்லா கொஸ்டினும் நல்லா ஆன்சர் பண்ணிட்டீங்க. உங்களுக்கு டிஸ்டிங்ஷன் கொடுக்கணும்னா தான் இந்த கொஸ்டின் வரும். What are the other drugs, alternate drugs? So, just list of drugs: cyclophosphamide, mycophenolate mofetil, levamisole, cyclosporine, tacrolimus. So, alternate drugs which we call as steroid sparing drugs. Either the patient is steroid resistant or steroid dependent with features of steroid toxicity. You have to consider the steroid sparing drugs or alternative drugs. So now currently our question is know what are the indications for renal biopsy. So steroid resistant, okay, you have to suspect other focal segmental glomerulosclerosis like that. Okay. Then steroid dependent with toxicity, you have to start on alternate drugs. Then family history with atypical presentation for renal biopsy. Age group, 2 to 6 years. Suppose the child 1 year old child is brought with nephrotic syndrome, then confirm it with renal biopsy. Okay. Then persistent hypertension eventually is not responding properly also, then you have to decide upon renal biopsy. So what is the prognosis? எல்லாம் கேட்பாங்கல்ல, ட்ரீட்மெண்ட்லாம் சொல்லிட்டு மதர் கேட்பாங்கப்பா, இது எப்போ தான் சரியான கேட்பாங்களா? So what is the prognosis in nephrotic syndrome? பெர்மனெண்டாக பிரச்சனையா renal patient ஆயிடுவாங்களா? ரிலாக்ஸ் ஒரு 2-3 ரிலாக்ஸ்க்கு அப்புறம் கேட்பாங்க, சார் இப்படி வந்துட்டே இருக்க வேண்டியதுன்னு கேட்பாங்களப்பா, அந்த சொல்லிட்டு மாத்திரை போட்டு நீங்கிட்டு வந்துட்டு. ஸோ மினிமல் சேஞ்ச் nephrotic syndrome usually has a good prognosis. Okay. The child may have repeated relapses. Treat it properly, treat the infection properly. Usually under 14 to 16 years, the age group reach panradom, child will go for remission. Okay. So we have seen so many cases going for remission. Steroid resistant cases kuda paathukom. One patient called Azarudin, from village near Model, Tirunelveli. Okay, for repeated steroid resistant, he gave cyclophosphamide, almost 9 cycles of cyclophosphamide. One day he came with total cellulitis, almost gangrene problem with total cellulitis. Okay. So then he treated it properly. By the time we 11th, 12th reached relapse he joined polytechnic. Then he just came for visit. And he'll come and see me. Sir, mother is also very happy. Then one day sir, so one of the advantage for you to treat the hepatic syndrome properly. Other than no results or like after 12 o'clock or cesarean section முடிச்சிட்டு வந்திருந்தேன். அந்த நேரத்தில் போய் வைப்பேரி கூட முடியாது. ஸோ பயங்கர பசி பார்த்து கடையெல்லாம் அடைச்சிட்டு ஒரே ஒரு கடை மட்டும் வந்தது. திருநெல்வேலி எங்கே தனிக்குனாலும் ஊசிட்டு இருக்கும். சரி. ஸோ பார்க்குறேன் ஏதாவது சாப்பிட்டு சார் எல்லாம் முடிஞ்சது கம்பெனி அடிக்க மட்டும் தான் இருக்குது. சரி ரெஸ்டேட் பண்ணிட்டு வெளியே வந்து ஒருத்தர் அம்மா வழியாக இருந்தாரு. சார் ரோட்டோட ஆம்லெட்லாம் கூட கிடைச்சிது. இப்போ வந்து சார் மாமா சார். So I took the credit completing the reference program. Any doubt? It's a short case study for you. And simple, it's a very straightforward procedure. Yeah. You can go from there. Any doubt? All clear right now? Yes.
Fluid insensible fluid loss.
Insensible come exactly calculate on there. Adults that we have 500 ml per day through skin and breathing already. So in children we take it as 250 to 300 ml.
250, 300 basically all fluid loss.
Wait.
Thank you.
Thank you, Dr. Senthil Kumaran, for that excellent presentation and taking me through the case in a very simple way. The nephrotic syndrome, if there is a case, it will be always kept for UGs as well as PGs. Whenever there is a case, we will get it.